you can't reduce all of what is goals of care into just one medical decision like code status, right? And so to better teach and show you what goals of care actually mean, and if you bring it up to a patient, they'll kind of question what that even means. So it's not something you even say to a patient. But I want to use what I call a decision tree to tell you what goals of care means in a patient's disease course and medical decision making. So at the root of the tree is one's health status and prognosis. You need to establish what the prognosis and what health status is to the patient and make sure they understand. That's why the first step of the serious illness conversation guide, put out of Boston, is elicit understanding of a patient. With all the doctors coming in and out, what have you taken away from the treatment plan or where things stand now? I use myself as an example. At this stage in my life, alhamdulillah, I think of myself as a fairly young and healthy man, and inshallah, I can expect to live a normal lifespan, hopefully even longer, inshallah. My goals of care right now are going to be much different than if I were 85 years old, right? So we have to really, or if I knew I only had 3 years to live. So you really have to establish health status and prognosis. Now, studies show that patients and families expect doctors to bring this up to them. And studies also show two things on the doctor's side: that A, they're not really good at communicating prognosis, surprise, and two, the closer they are to patients, the more likely they are to overestimate prognosis. So the patient that's coming in every week because of heart failure, their doctors are thinking, oh, this person's going to live longer, and surprise, they're on death's door. So it's a science, but it's also one that requires skill in communication, comfort in the discomfort, right, in the uncomfortable conversations. So it requires a lot of training, and a lot of palliative care training has to deal with communication. Now, on the branches of the tree are medical decisions. And medical decisions, I've listed some end-of-life medical decisions there on the branches that come up often at or near the end of life. Now, too often in healthcare, I see, okay, deliver some devastating news about prognosis or diagnosis, your loved one's dying, or something that's really devastating, and immediately afterwards, they say, okay, here's the menu of options. Which one would you like? Which branch would you like to reach for? But trees don't grow that way. And I know we're often pressed for time, especially in the hospital, but you cannot bypass the trunk of the tree. Goals of care, values, priorities. One of my favorite things to do is when I'm in a family meeting and there are many doctors involved, like a neurologist and an intensivist and a nephrologist, and they have all this very important medical data and clinical judgment to share with the family. And before we get started, I just put the brakes on everything, because everybody wants to just regurgitate medical data and tell them the latest creatinine or whatever it is. And I say, wait, this is the first time we meet your father, and obviously he can't speak to us now given his illness. Do you mind telling us about your father? Share with us a memory that resonates with you, that tells us about the person we are treating. And they're emotional, right? They know their father is not just a patient to them. And just like that, we have to focus on the people we are treating and not just the lab values or the CAT scan results or the diagnoses that they come with. And so focusing on the trunk of the tree is really important, so that in the last stage of the serious illness conversation guide, you're often spending the least amount of time, if you're doing it right, if you're doing palliative care right, around sharing a recommendation for a medical decision. Once you establish who the person is and what's important to them, finding out which branch to reach for becomes a lot easier.